Okay, ladies and gentlemen, we're going to get started with the second breakout session. The challenges of progressive MS is the room that you're in now. Our presenter today is Dr. Hentati. He is the Clinical Assistant Professor of Neurology, University of Chicago, Pritzker School of Medicine, and the Director of North Shore University Health System Multiple Sclerosis Center, which was recently designated as a Center for Comprehensive MS Care through the National MS Society. Dr. Hentati has been an investigator in numerous clinical trials, and he serves on the Clinical Advisory Committee of the chapter. We will have a Q&A when the presentation ends, so if you can give all your attention to the doctor, please.
I'm happy to talk about progressive MS, a form of MS that has been relatively neglected, if I will, because of challenges related to it. So now I start by the definition. The definition of progressive MS is clinical, meaning that a steady and slow progression of disability independent of relapses in patients with MS. So the patient has to have MS, and the disease is slowly progressive. There are two forms of progressive MS. The primary progressive MS form and the secondary progressive form of MS. And I'll talk about those both a little later. But each one can be classified in progressive MS with relapses, without relapses, and with relapses, and without relapses each. It's important to classify the condition like this because of therapeutic implications. Now, I cannot talk about progressive MS without talking about all the forms of MS, particularly the most common of them, which is relapsing remitting MS. You see here, this is a depiction of what a disability would progress in a patient with relapsing remitting MS. Obviously, it's the majority of patients. Patients will have relapses. These are the rectangle here. At one point, initially recover, and then at one point, there is some disability that persists. The disability gets over time become more and more pronounced as the patient has more relapses, and at one point the disease stabilizes. The relapsing form that become progressive MS, the beginning is the same as relapsing remitting, but at one point the patient will have progressive worsening of disability without relapse. So obviously from now you can tell how can you differentiate between this and this form, and that's one of the challenges that we face typically. Now, the primary progressive form of MS, which is the least common, is the hardest to diagnose, and because the patient will have progressive worsening of the disease without ever have any relapse. So, sorry, I cannot see. Okay. So now this is a form that is kind of separated. Is a form where the patient has relapses. He never recovered after the first relapse, but then in between the relapse, the patient never became totally stable, and then the patient will become progressive after this. So this is a very rare form. It's very hard to differentiate it from this form, obviously, and actually, and again, you can see that it's very difficult to differentiate between this and this, if the patient did not notice any relapse. Is it primary progressive or secondary progressive MS? It's very difficult to differentiate between them. This is a list of symptoms that can. This is a list of symptoms that a patient with MS can or may experience at one point of their either related to relapse or they come independently of relapse, but mostly related to relapse. So sensory symptoms, numbness and tingling, motor symptoms, weakness, spasticity, difficulty with balance, visual, optic neuritis is one of them, double vision, brainstem dysfunction, we call them brain dysfunction, is slurry speech, vertigo, facial weakness and numbness, and very common bladder and bowel problems, as well as sexual problems. The less what we call non-focal. All of these symptoms are related to lesion in one area in the brain. each one will, some area in the brain, when they are lesions, will cause symptoms associated with them. Now, the less focal or the cognitive difficulty with memory, memory problems, and that they have been, ignored for years because they are not explained by a focal lesion. There is no area in the brain that will say this is a cognitive area in the brain. Even the memory area is really not affected by MS. Now, the depression also is part of MS, but no one has really there is no location. Fatigue also. Seizures are very rare in MS, and headache, facial pain, limb pain are rare because also there is no pain area in the brain. Although, now with the sensory area, the same sensory area here, they may generate pain if they are affected in a certain way. Now, the other feature of MS is MRI. I know the clinical features are very important, but MRI is becoming now the standard of diagnostic MS. This is because MS has a pattern that is kind of particular. It's not specific, but it's particular to the disease. The lesion, I'm sure that many of you heard about the T2 hyperdensity, these bright spots in the brain, which, if you look at the different sequences, some of them will become dark, and these called black holes. And when you inject a dye, at one point, some patient will have these enhancing lesions. You see this bright signal? These are enhancing lesions. These are actually lesions that are inflamed at the time the patient did the MRI. These, the black holes that do not enhance, and the dark holes are basically scars. Black holes are reflect much more damage than the white scar. This is the hallmark of MS, particularly relapsing remitting MS. Now, what a typical patient, this is just a brief to show you how a typical patient with MS would progress. This is just a prototypical, so not everybody will have to go through this. Initially, the patient will be preclinical, so the patient will have lesion in the brain, these bright red or dark, these scars that accumulate over time, but the patient did not feel anything, and then at one point he has the first relapse, clinical relapse. At that time, most patients will have their investigation done, and at that time you find that the patient has already few spots in the brain that he's not aware of. What happened afterwards is that the lesion accumulate over time. The lesion accumulate over time, and this blue line, indicate the volume of the lesion. So the lesion accumulate over time, but the patient will have a relapse in the relapsing form of the disease. So that's mean that, but you can see that there is a lot of lesions that happen, and the patient doesn't have a relapse. So there is many more lesions in the brain that's clinical relapse. That's why it's important now to monitor the brain MRI, because it will give us a better idea on how the disease is progressing rather than waiting for a relapse. But at one point, in some patients, typically one patient will have a progressive of disability regardless of whether they have a relapse. And in MRI also, what you see is that the disease, the accumulation of lesion is not as pronounced. So the most accumulation of lesion takes place when the patient has a relapsing form of the disease. When they become progressive, the MRI is less active. And that's the hallmark of progressive MS. MRI activity is way much less than clinical activity. Now, so that's the difference between progressive MS and relapsing MS is simple. It's clinically, patient would have relapsing MS, they have relapse. These are symptoms, one of the two symptoms, numbness or tingling, one side or the other, vision and sometimes balance problem, they come together, one or two symptoms. They start rapidly, reach a point, and then start improving, either go away completely, or some residual persist. And usually it takes about at least 12 weeks for the symptoms 12 weeks to say the symptoms is going to persist for more than forever. Progressive MS, you cannot say when the progressive MS starts. So the patient has weakness, and if the weakness starts getting progressively worse, usually very slowly. So you don't know, you have to really monitor the patient for a long time, or the patient has to, take note or have better idea on how much he can do every day to see whether the patient has progressive MS. The other thing is that patients with progressive MS, there is no improvement. When they reach a point, they usually don't improve. But I'll tell you that this is very, very, very difficult to prove. Again, some patients with progressive MS may have relapses. So it's not like if you have relapsing MS, if you have progressive MS, you cannot have relapse. So this is again the list of all the symptoms that relapsing remitting MS does. Progressive MS has primarily only motor symptoms. And it's actually, that's what it's defined. It's the motor symptoms that get progressively worse in MS patients. The bowel or bladder symptoms usually are residual from relapses. They get either worse or they stay the same. The cognitive difficulty is controversial. I haven't seen any paper to show that there is a progressive worsening of cognitive function in patients with progressive MS. I haven't seen that. It's very hard to monitor, to quantify cognitive function in MS patients. Very hard, so that's why it's the lack of tool, it's probably part of the problem as well. Fatigue is also part of MS. I have few patients who do have progressive fatigue over time. But I don't know whether that can be used as a monitor for progressive MS or not. I am not sure that is true. But you never see a person who has progressive loss of vision. You never see a patient who has progressive double vision. You never see a patient who has progressive worsening of symptom of tingling, actually. So these are, so it sounds, it seems like the progressive MS is kind of slightly different, even by looking at that from relapsing remitting MS. So how can we determine whether the patient is getting progressive MS? In research, we use what's called the EDSS. The EDSS, part of the EDSS test is to ask the patient to walk 500 meters. But if the patient knows how much can he walk, then it will be, the patient can determine it himself. So it's basically how far can you walk without resting, without stopping. It's not how much you can do in a day and how much you can walk till the leg or something will feel you cannot do it anymore. And I'm sure the patient who feel that know what I'm talking about. The other way we measure it is basically speed of 24 when you walk a certain distance. Speed is not totally weakness, but that's a way to determine weakness. 25 feet. It's easy to do, much easier than EDSS. The other simple way to monitor it is to see the patient exam. When you see the neurologist, he will push it. I push the squeeze my fingers or push here, push this. This is a way to monitor to determine the muscle strength. And we have a scale. Obviously, it's not as good as because it's very subjective, and the patient can be in the morning must be stronger than the evening, and it's hard really. You have to see a pattern to say that the patient has progressive MS. Now, in my own experience, which I haven't seen anyone who was secondary progressive MS who did not have some weakness after the relapse. So it's always built on some pre-existing weakness. And the other forms, there are two forms of progressive MS. One of them is the patient has some weakness, like leg weak from the previous relapse, and then the leg weakness starts getting progressively worse, but never affect the other side, never affect the arms. There is other type of patient whom they start having weakness in the leg, but then as time goes on, they get the arm, the other leg, and the trunk, and the weakness gets progressively spreading bit by bit over time. So I think there might be two forms, at least two forms of progressive MS. But in all cases, it affects motor function. Spasticity also is part of the motor function. The spasticity and the strength are carried by the same fiber. So a patient, usually how to measure spasticity is to ask the patient, do you have spasm at night especially, or when you stress your leg, how much spasm the leg starts, how many spasms in the leg you experience. Obviously, when you can measure it by seeing the patient walking. There is a particular way the patient walks when he has spasticity, and also the degree of stiffness when on exam. You see, I'm sure that when you see a neurologist, you must have examination for that particular function. So the spasticity is almost always associated with weakness. Some people will have more spasticity than weakness. Some people have much more weakness than spasticity, but they are all go together. But at one point, when the weakness becomes very severe, spasticity may get better on its own. So that's another feature of spasticity. Now, the other difference that I talked about this earlier, the other major differences between relapsing remitting MS and progressive MS is the MRI. The MRI is very inactive in progressive MS. But the other feature also, almost all patients with progressive MS have some sort of spinal cord injury. So spinal cord is very important. Involvement of the spinal cord seems to be important in predicting patients having progressive MS. So progressive MS is the prototype, is the real challenge, the real dilemma of MS, which the patient gets progressively worse, but the MRI is stable. So this would suggest that it's slightly different. It's at least in some aspect different from relapsing remitting MS, because in relapsing remitting MS, the MRI actually is more active than disease itself. So that makes it, that's what creates the difference. This is hopefully not as hard as the picture you saw earlier this morning, but this is what the motor system works. How does the motor system work? So it starts the neurons start in the brain, and you can see that this red neuron goes all the way from the brain all the way to the lower spine. You see how long it is. It's maybe it's 20 microns, 20 micron in size, but it's like a couple of feet long. So these are the longest, and the green ones, I mean, I mark them in green. They go to the arms, and the shorter go to the face. So that's as simple as that. They cross the midline. So if you have a lesion here, you will get, if someone has a lesion on the, let's say on the left side, the weakness will be the right side of his body. If the lesion in the spinal cord, then both legs will be involved. So this is, okay? Now, this is where the motor system is. It's very small cable, basically, in the spinal cord. That's what it is. And you can even see you cannot see them, but by experimentation, they prove that actually the motor fibers that goes to the leg are a little bit are at the side, and from the fibers that go to the face, or those that go to the arms. So what are the characteristics of the motor system? And the characteristic of the motor system, in my opinion, will determine why is it more effective. Because in progressive MS, because one. We know that I told you already that the disturbance of the motor system causes weakness and spasticity. It is the longest pathway of the brain. It is also the pathway that has the thickest myelin. So long and thick myelin means that it's more vulnerable. That's the rule in neurology. It's most vulnerable to demyelination because it has more myelin, and to all kind of disturbance in the brain. It will be vulnerable to that. Because, it's like it's called the empire phenomenon. So if you have larger empires, when they are very big, they can expand thousands and thousands of miles. But when the capital become a little bit not strong enough, the first provinces that secede will be the furthest away from them. So because it's very hard to move army back and forth to this area. And that's exactly what happened in neurons. Longer neurons have very hard time maintaining the trophism of when they are in the very, very end of the axon, when they are very long. Now, this is a schematic representation of the motor system. So this is what everybody born with. It's like a cable that goes from the brain all the way to the arm and leg. Basically, everybody has a number of these fibers, electric wires, if you will, vary from one person to another. So, but how it works, the motor system works as needed basically. So if you do like 100 feet, 50 feet at a time and sit, this is how much you are going to activate, just small part of it. If you want to walk a couple of miles, then you have to activate a little bit more. And at one point, this is your maximum capacity. Everybody has a certain limit of distance that when he walks, he will have a problem. Sometimes you challenge yourself to do it, but most of us don't because it's like a few miles. Now, so in relapsing MS, It's very easy. You know, the lesion, if the lesion is here, so which will show up, which would affect the motor strip on the left side here. You can see it as a lesion in the spine, you know, easily white spot in the cervical spine on MRI, and the result will be weakness. The patient will have weakness on the left, in this particular case, in the left lower extremity, maybe a little bit the upper extremity, but mostly the lower extremity. In progressive MS, so in this particular case, sorry, if the lesion recovers fully, fine. If the lesion doesn't recover fully and keeps some deficit, some scarring, what the scarring does is basically reduce your capacity, reduce the capacity of the fiber. So you have less fiber to activate when you have to challenge it. So in this patient, at one point, they will have a limit. So if they walk, for example, a couple of miles or 1.5 miles, and they have to stop. They have to stop, rest, and till the thing will not regenerate, till basically the chemicals in the axon regenerate, and then he can walk. So there is a diminish of the limit of what the patient can do. What progressive MS does, though, is a progressive loss of this reserve. So the reserve, the patient will have certain reserve here. I mean, this is normal reserve. So at one point, some decrease of reserve, so the patient can go, you know, almost normal. At one point, you will start feeling that there is a limit as how far can you go. And here, there is only very little, few steps that the patient can do. And sometimes he cannot walk at all because of lack of fibers that are left to activate the muscle. So you can tell how it's different. So it seems like MS, progressive MS, is different from relapsing MS. It's much easier to, at least, you know, it's relatively easier to understand the concept of MS. You know, relapsing MS, lesion, the electricity doesn't go through, consequence, simple. Here, we don't know why the fiber starts losing fiber like this. And there are two hypotheses. One of them is it inflammation or is it degeneration? Inflammation, you know, everybody knows what inflammation is. You know, area of inflammation is in one area of the brain. You can see it on MRI. You can see how it works. You can see how much scar is left. Degeneration is a little bit more complex. Degeneration, because there is no good definition of degeneration. You know, and you can say, what do you mean degeneration? Is it loss of neurons? Is it loss of axons? And why some people have this, start having this progressive loss of neurons or axons, and others don't. And what cell degenerate? Is it the motor strip cell only? Is it all the cells in the brain? It's very, very hard to tell. This is a scheme to show you how a simple lesion will show up on MS. This is a cartoon to show how MS inflammatory lesion does. You know, the inflammatory lesion, you have this is neurons, this is axons. The cells come, destroy whatever they destroy from the myelin. These dots are axons that have no myelin left. You know, these dots are axons. And at one point, all the immune cells will go away. There is a scar. Some regeneration takes place. Some axons remain non-myelin. And you heard this morning about this relative, it's very, very ambitious program to inject the cells that produce myelin, and hopefully these will be remyelinated. Now it's looking at the same, but in the same picture on a different angle. This is what happened in relapsing rheumatic lesion, and you can see that at one point after the inflammation is totally resolved, the scar, some of the neurons, some of the axons will be lost. So in progressive MS, in my opinion, it sounds like it's not that. It seems like it's, at least in some of them, or at least one of potential mechanism is that this is the normal, you know, the motor strip, the motor fiber. What happens is there is a progressive loss of these longer axons, progressive loss of axons. And that's a challenge. That is really a challenge, because what can cause that normally? If, let's say, forget about MS, what can cause progressive loss of axons? Aging is one of them. Toxins, vitamin deficiency, but also anything else. Anything that makes a neuron sick may cause primarily loss of longer axons. In humans, these are the longest axon, is the motor axon. Unfortunately, these are the ones that we use the most to live. That's the problem. Now, so the question is there any smoldering inflammation, or is it multiple inflammatory lesions here and there that create the brain to be all of it sick and it show up only in the motor system, or what is the exact mechanism? So this is the inflammation. So the smoldering inflammation hypothesis is these cells, the yellow cells, the inflammatory cells, never go away. They're still there. They keep munching here and there, killing neurons and killing the axons. The regeneration takes place, but there is not enough regeneration so that the destruction is a little bit more than regeneration, so that the person starts getting progressively worse. The progressive loss of damage is these axons that you heard this morning, these axons which have any myelin around them. They are more prone. They are not protected. They cannot survive long time, so they start regenerating on their own. So there is also one relatively popular concept, is that actually progressive MS is an inflammatory disease. It's not a degenerative disease. But all it is that there is much more lesion in the gray matter. The gray matter we cannot see on MRI. And this is how I try to show it here. So you see this is a cartoon of the brains of a brain, MRI. You see this is the white spot, the spots in the white matter. The white matter show very dark, but you cannot see this well. You cannot see it because there is not enough contrast. It's as simple as that. There is not enough contrast in the gray matter, so you cannot see the lesion. And some, like the Mayo Clinic group, and actually even the major groups, the Mayo Clinic, Cleveland Clinic, they really think that because they looked at the progressive MS in autopsy and they found that there is a lot of inflammation around the brain. And they think that it's a different type of inflammation that progresses than relapsing remitting MS. Relapsing remitting MS would be a T-cell inflammation, T lymphocyte, while this is primarily driven by B lymphocyte. That's why, it's a good explanation. The medication we have that are for relapsing remitting and primarily against T cells will not work well on this particular type of inflammation. So, I think the mechanism is probably all of it, and probably vary from one person to another. And that's why it's important for you when you see a neurologist, or to determine how much you think it's more smoldering infection, how much is aging, or how much there is inflammation, how much there is actually inflammation in the brain. And actually, I think it's important to determine how much inflammation because if there is inflammation, I think there is some benefit that you can get from disease-modifying therapy that we have. So how to manage progressive MS? First of all, you have to recognize if the patient has a progressive MS or not. At this point, it's probably not crucially important because we don't have good medication to stop the disease, but I'm sure that at one point it's become very important to know. The other question is, obviously, we need to manage symptoms, and also can we progress, can we stop the progression? And that's the question, obviously, we need to answer every time with a patient, whether he has progressive MS or relapsing remitting MS. So it is difficult to determine when the patient has progressive MS. It's usually after the fact, in the fact that usually the patient say, you look at the EDSS or look at 25 feet and you look at the patient getting progressively worse. It takes a year or two to say, oh, yeah, you know what, you have progressive MS and you started 2 years ago. You cannot say, oh, today I think you are having progressive MS. You cannot do that. That is a challenge, actually. The other thing is that it's very difficult to separate between progressive MS and stable MS, because, particularly patients who have already some degree of weakness in the limb. And that is a challenge because, everybody with MS know that. They have good days and bad days. They're usually better in the morning and a little bit worse in the evening. When they get tired, they cannot walk as well as if they are not. So how can we take all these factors outside neutralize them all and see what the patient does. It's very difficult. Every time there is something that comes up will make patient not be able to walk, so it's hard to determine. So that's why the patient himself needs to, challenge, walk every day or every day or whatever, and see how far can you walk without needing to rest. If you want to know if you have MS, the progressive MS. I don't know if it is crucial to know at this point. So again, this is what we use. Again, EDSS, 3.45 walk, but they are not very reliable because there are a lot of external factors that we cannot account for that makes us determine with certainty. There are others who try to solve the problem, who say, you know what, if you reach an EDSS of 4, you have progressive MS. EDSS of 4 is the EDSS when the patient can barely make it to 500 meters. And there is a study that's based on that. That's why I think they are not very valid. There are a lot of patients who reach an EDSS of 4 and they never progress after that. So the others would say, oh yeah, you know what, you have MS for 30 years. You must have progressive MS. That is totally not true. It cannot be true. Some will think, you have a couple of lesions in the spinal cord, 2 or 3 lesions in the brain, and you have weakness in the leg, then you have primary progressive MS. That's the way it is. Without proving, and I've seen that diagnosis made actually. I don't think that's true. I mean, I think the patient has to, you should prove that there is progression of limitation of reserve as time goes on, and we should prove to say that it's progressive. And I think we should differentiate between progressive MS that spreads from one limb to another to progressive MS that doesn't spread. Because the progressive MS doesn't spread, it's usually a little bit better because if you have one leg that is weak, the other one strong, most people will be able to walk somehow without major limitation. The other challenge is it progressive or secondary or primary progressive. It's secondary progressive if the patient has for a long time and relapses and everything. It is easy, and then they start getting progressive, and then it's secondary progressive. The problem is that for patients who have progressive weakness without well-defined relapse, and that, that can be first difficult to diagnose because, MS, you have to have relapses today. That's the definition of MS. So you have to do MRI, spine MRIs, and most of the cases spinal tap to see if there is any inflammatory. But again, if the patient has a small relapse that he did not know about, if he has one single relapse that the patient did not know about, then it's no longer primary progressive, secondary progressive. See how the definition is kind of very subjective and purely clinical. Unfortunately, we don't have any marker, we don't have a blood marker or an MRI marker to say that the patient has progressive MS. And the axonal loss that I told you about earlier, you cannot image, you cannot see it on MRI, So that's what makes it much difficult. And even if you see it, doesn't mean it's progressive because some people will have some loss of axon, but they never progress. So management of weakness is difficult simply because there is no good medication to improve strength. Possibly foraminopyridine may have some effect on strength, and some people will benefit from it. So if the patient has problem walking, they have to use the proper walk, or basically putting a band-aid. There is no good way to reverse weakness, and that's why it's important to prevent it from happening. Now, exercise is extremely important, and I put this to show you what exercise can do in a scientific, cartoon way, if you want to. This is a normal person. This is a normal reserve, and you are born with it. We are born with it. This we cannot. You can exercise as much as you want. You cannot increase the number of fibers that go from the brain to the motor fibers. But what exercise can do, I don't see the here. What exercise can do can make them bigger. The axons, the number is the same, but they are more easy to use. So what happens is that by challenging doing more exercise, what you end up increase your capacity, increase your plasticity, what's called the brain plasticity. So there is more reserve. So if MS will cause that much damage if you don't exercise. With the same damage, you can with the same damage, you can do much more if you exercise. So that's why it's the best treatment for progressive MS, progressive weakness, is exercise. That's the best symptomatic treatment we have. Management of spasticity is little bit easier. I'm not going to a whole lot easier. There are a couple of medications that we use. You can use oral if the spasticity is too bad. You can even put a pump in the spine that will help the spasticity, so that makes patient comfortable. Stretching exercises, challenging is also very important. Bladder and bowel control, as I told you, these are not particularly feature of progressive MS, but they're extremely common in patients with progressive MS. And the treatment depends on whether urgency or retention depends on that. So the question, what are the disease-modifying therapy? In other words, is there any medication that stops progressive MS? The older ones, interferon and glatiramer acetate, are shown to not affect the progression at all. I mean, even there is a initial trial in Europe with interferon beta that showed some benefit. It turned out that actually they recruited patients who have relapsing remitting or who still have relapsing. And that's another proof that these drugs work only on the inflammatory component of the disease. Basically, the relapses only. Doesn't affect the progression of the disease itself. Now, the newer ones like natalizumab, fingolimod, teriflunomide, and dimethyl they have not been tried yet, or they are in the process of being tried to see if they have any effect on progression. So as I told you, what is important is to know is that disease-modifying therapy affects spots in the brain, accumulation of lesion and inflammation. So in my opinion, if even the patient has progressive MS, or he feels like it's progressive, and when you do the MRI, you see new lesion and new enhancing lesion, I think he may benefit. That's a personal view. I think he may benefit from medication. We may not be able to stop the axonal loss, but if we reduce the inflammation, we may do something. So obviously, we need a lot of trials to help. We need to understand what is progressive MS well, and then we need to more medication. I know there are a lot of medications that have been tried for progressive MS, and hopefully I'm skeptical that they're going to work because they're all derived from the same idea of anti-inflammatory medication rather than something that will help axonal loss. And we don't have anything to help axonal loss. Axonal loss is the same feature for neuropathy. That's what neuropathy is axonal loss in the leg, and there is no good medication for that. So knowing that, so we know that vitamin deficiency can cause axonal loss. Vitamin deficiency, vitamin D, unfortunately, interestingly, did not show that it had any effect on axonal loss, but vitamin D's are. So I don't think you should load on the vitamins, but there is now ways to measure the vitamin levels. If the vitamin level is normal, then whatever you are doing is fine. I don't think you should overdo vitamins because although they are not harmful, some of them may be harmful when they are of toxic levels, but you don't need that. You are not going to gain more. It's like putting gas in a car that is full of gas. You look like you are putting something, but all of it goes to you're losing your money. That's all what you're doing. So avoid toxins, alcohol, and you heard today about tobacco. So these although they don't cause, excessive alcohol, although they don't seem to be causing axonal damage, but they make the neuron a little bit sick, and sick neuron cannot maintain their long axon. And general good health, exercise, blood pressure, high cholesterol, to prevent strokes. Strokes are damage to the brain, reduce the brain plasticity, reduce the brain capacity, and they can make MS worse. Obviously prevention will be the best way. If as soon as the patient develops symptoms of MS, treatment. The ideal treatment is to stop the disease before the patient, or the patient will never have a weakness. Whether that's correct or not with the medication we have now, we have not proven yet. but it sounds logical. It sounds common sense, and that's why most people would treat disease, MS early, whether that's progressive, relapsing remitting MS early. And this is all I'm going to say today, and hopefully you like it.
Okay, a couple questions here.
Hi, Dr. Hentati. For people that have primary progressive MS, they have these, medications approved just for relapsing remitting. I know you showed that they really haven't tried them yet, but of the new ones now, or any other medicines, what do you think that a primary progressive person should take? It'll give them help or something.
Good question. I really don't know if there is anyone that is better than the other ones. I have no idea. I don't really know. What I will do if I will use the the ones that will cause you the least, they will cause the least harm, the least harmful ones. And I would not treat unless I see new lesion on the brain. I will, new lesions. You have to prove that there is an inflammatory component of it. Some would claim that some of these medications have a non-inflammatory, like neuroprotective effect, and that's implied that it will protect the neurodegeneration and that neurodegeneration. This has not been proven yet. So, to be on I think you should be on the safe side rather than the aggressive side till we prove that this one drug is more effective than the other.
Dr. Hentati?
Yes.
In the earlier session this morning, you had mentioned that there was a compound similar to fingolimod that's being studied now for progressive. What stage is that trial in?
Phase 3 started.
Stage 3?
Started.
When is that the results going to be released?
It will take minimum of 2 years to get the result. So I think 3 to 4 years to get the result. Because it's 2 years trial, and then enrollment. It's not like you start today. Every patient will come today to get into the trial. It will take you a year to enroll whatever the 1,000 patients they need, and then once the last patient is enrolled, it will take 2 years to get all these last patients who enrolled data on to get the data. So it's at least 3 to 4 years from now.
Thank you.
My question for you is, the newest drug on the market is Tecfidera. It is prescribed for relapse remitting. It is said that it may have some neuroprotective agent. Would you prescribe Tecfidera for a primary progressive patient that you have?
That is a good question, and my answer is the same. I will have to talk to the patient, but why Tecfidera? Why the other ones? I mean, that's my first reflex. They all of them has some neuroprotective, potential neuroprotective. If there is evidence of new lesion on the brain MRI, I will treat. Tecfidera is also fine. I mean, the other pills, the other injectable as well.
Did I understand you correctly? As if there appears to be new inflammation on an MRI, then yes?
Yes, I will treat. Yep, exactly.
Can you talk to the prolonged use of steroids, the high-dose steroids? It works on me, however, nothing else seems to work on me.
Yeah, prolonged use of steroids is it's like any other. I think I have a couple of patients who were on long steroids. I mean, as soon as you go, as soon as you go down a certain level, the patient will work and cannot walk, or he's walking, or her walking is not as good as before. it has a long-term problem. The problem is that weight gain, the bone gets sick, immunosuppression. Some people with long-term steroids, even 50 milligrams, and even 50 milligrams a day. I have patients who have 50 milligrams a day. She, never had any problem from steroids, so kind of used to it, fine. Everybody is reluctant to do that, So I would suggest to try to use the disease-modifying therapy that we have that will allow you to get better. Try the disease-modifying therapies and then start reducing the steroids bit by bit and see whether the effect becomes. That's what I would do.
Okay, if no one has any other questions, then we're going to ask you to please be reminded to fill out your surveys and pass those in at the front. And we're going to thank the doctor again for his time and enjoy the rest of your afternoon. Thank you.